Hello again and happy Sunday from Metro Manila, the Philippines, Southeastern Asia. This video lesson is intended for those people who want to rationally and objectively compare the current, still unfortunately ongoing and sadly still in many countries advancing coronavirus pandemic with a similar pandemic, the so-called Spanish influenza or Spanish flu, which affected much of the world about 1 century ago, more precisely from 1918 to 1920, and came in 3 waves, resulting in between 50 million and 100 million deaths out of a population of under 2 billion people worldwide. So far, we know the numbers: over 530,000 people are recorded as having died out of a population of almost exactly 7.8 billion. In other words, we can say that so far the COVID-19 pandemic has not been even nearly as deadly as the Spanish influenza was. Of course, we have to remember that in the century that has passed since the Spanish influenza, the medical science worldwide, especially, but by no means exclusively, in the so-called Western countries, meaning European countries, North American countries, Canada and the United States, Australia and New Zealand, has advanced by leaps and bounds. For example, the early detection of diseases is much more common than it was a century ago. The penicillin actually was invented as a response to the Spanish influenza epidemic or pandemic a century ago. Now there are, for example, a lot more effective antibiotics in tens of countries, especially but by no means exclusively in the Western countries. And we have to remember that there are reasonably prosperous countries nowadays also in Latin America, Africa, here in Asia, and some in Oceania, in addition to Australia and New Zealand. We have to remember that a century ago, aviation or flying by airplanes was still in its infancy. In fact, during that pandemic, the first recorded transatlantic flight was made in 1919, the first one, by a primitive biplane, and it was actually a miracle that those 2 pilots, Alcock and Brown, were able to survive the flight because they had to fight against, for example, fog and sleet. And they really feared at some point while crossing the North Atlantic from Newfoundland, which is now Canada's easternmost province, then it was a separate British colony, to Ireland, that their airplane would become inoperable and would crash into the Atlantic Ocean. Nowadays, airplanes are much more reliable, much easier to control, much bigger and much faster, which means, of course, medically speaking, that medical scientists, doctors, and of course, vaccinators and nurses can be flown quickly around the world to trouble spots. And of course, we have a number of helicopters as well. And many aircraft nowadays are equipped with medical equipment and, of course, medicines. The hospitals are much more sanitized in most countries of the world than they were 1 century ago. And then already from childhood, people in most countries are now told, for example, about the importance of regularly washing their hands. And when they have to go to the comfort rooms or toilets, to make sure that they wash their hands and other body parts necessary. And of course, about the importance of, for example, not eating leftovers from other people, and not eating with their hands when they can avoid it, and using disinfectants, and of course brushing their teeth regularly. And nowadays, if a person develops the COVID-19 virus, especially in the more developed countries, it is fairly easy for him or her to self-isolate if he or she is asymptomatic. A century ago, some primitive, because even in North America, Europe, Australia, and New Zealand, or the Western countries, um, medicine was much less advanced than it is today. So it is possible for there to be a lot fewer deaths from this pandemic than there were of the Spanish flu. And also, we have to remember the fact that the communications have advanced a lot. A century ago, the television did not exist. The radio did. However, there were tens of countries in the world, or tens of independent countries of today, most of which were still colonies, especially in Africa and here in Asia, which did not have radio receivers or only had a few of them. Basically, the upper class people had them. Nowadays, it's possible even for lower class people to listen to radio broadcasts, for example, on their cell phones, even in third world countries like the Philippines. The internet did not exist and would not exist in any form before about 1969, when its main predecessor, ARPANET, was created. The television did not exist even in its most primitive animated form. That was only invented sometime in the 1920s. And worldwide broadcasts, even radio broadcasts, did not yet exist, since there simply were not enough transmitters available around the world. We would move into those luxuries basically only after the Second World War. In other words, due to our huge advances in medical science, in personal hygiene, in information about the proliferation of and creation of germs that cause such diseases, and of course about healthy diet, and due to our huge advances in worldwide communications, it is possible to monitor this disease much better than it was to monitor the influenza pandemic or epidemic 1 century ago. And also to anticipate a possible second or a third wave much more easily, and to prepare people for such waves. For example, by reclosing schools and offices and so forth, reimposing strict lockdown measures, recanceling mass events, whether they are secular or religious ones, than it was 1 century ago, when there always was that time lag of at least several or many hours or 1 or 2 days, because even the telegrams were not commonly used yet, not very commonly used yet, especially in the countrysides of Latin America, Africa, Asia, or then the scattered Oceanian islands, with the exception of especially Australia and New Zealand. And while the internet coverage is far from perfect, it is now much better than it was even 10, 15, or 20 years ago. But let us now move into certain scholarly articles on this topic, and I will then interject my own interpretations and remarks and additions wherever appropriate. The Conversation, which is a Canadian website for discussing current events. Its two slogans are academic rigor, journalistic flair. This article was published about 1 month ago on June the 4th, 2020. Compare the flu pandemic of 1918 and COVID-19 with caution. The past is not a prediction. One American lady who is very old, 102 years old, was interviewed this past week, apparently, or then maybe earlier, by a journalist of the cable news network. Her daughter, or maybe one of her daughters, came to visit her. She's in a nursing home, and for a 102-year-old, her voice was remarkably strong. Toddler, and now from the COVID-19 virus as a centenarian. It's heartwarming to hear such stories. And then of that 100-year-old veteran of World War II in Britain, who with his rollator has been walking around his yard to raise money for, I think, research to fight against the coronavirus epidemic. And I think a Belgian war veteran in his 90s who has been doing a similar activity. Obviously, surviving the Spanish flu developed some sort of an immunity against similar diseases. And one of the reasons why Africa has had still comparatively few infections and deaths compared to Europe and North America, especially the United States, is that there are so many tropical and similar diseases in Africa because of, for example, the lower levels of hygiene and infrastructure and the less developed medical science. And those Africans who do survive these tropical and similar diseases, such as malaria, already develop a higher and stronger level of natural or biological immunity, non-medical immunity to such diseases than do, for example, the North Americans, Europeans, Australians, and New Zealanders and other people in the more advanced developed countries. People have turned to historical experience with influenza pandemics to try to make sense of COVID-19, and for good reason. Influenza and coronavirus share basic similarities in the way they are transmitted via respiratory droplets, so droplets from breath, and of course if people cough or sneeze and so forth, and the surfaces they land on. Descriptions of H1N1 influenza patients in 1918 to 19 echo the respiratory failure of COVID-19 sufferers a century later. Lessons from efforts to mitigate the spread of flu in 1918 to 19 have justifiably guided this pandemic's policies, promoting non-pharmaceutical interventions such as physical distancing, or as we now call it, social distancing, and school closures. Current discussions about scaling back social distancing measures and opening up the country frequently refer to waves of disease that characterized the dramatic mortality of H1N1 influenza in three major peaks in 1918 to 19. As COVID-19 rates begin to steady in some parts of the US, unfortunately they are rising in most states now, people today are nervously eyeing the second wave of influenza that came in the autumn of 1918, the same autumn when the official fighting in the First World War ended. That's, of course, one difference. There is no official World War now going on, although some people say, and with quite good justification, that we've had some form of the Third World War going on for almost 19 years, ever since the 9/11 attacks on the United States by Al-Qaeda activists in September 2001. But it hasn't yet escalated into a full-scale Third World War. But it could be some kind of early 21st century parallel of the Cold War, which lasted from either 1945 or 1947 until the Soviet Union's final collapse in 1991. And also autumn 1918 was that pandemic's, or the Spanish influenza's, deadliest period. Waves evoke predictability, however, and COVID-19 has been hard to predict. Despite the variable or valuable lessons drawn from past influenza outbreaks, how pandemic influenza struck in 1918 is not a template for what will happen with COVID-19 in the coming months. As a historian and a virologist, so there are two writers to this article, we believe this comparison of two pandemics has contributed to public confusion about what to expect from flattening the curve. Key divergences in the socio-political contexts of 1918 to 19, of course, with the end of the fighting of the First World War and then the several months of peace negotiations leading to the dissatisfactory Treaty of Versailles in June 1919, which actually contained the seeds of another World War because it unfairly and one-sidedly blamed Germany for starting the First World War, even though it was Germany's close ally, Austria-Hungary, which actually started it. And even though there had been an arms race, both among the Central Powers, especially Germany and Austria, to a smaller extent Italy, and the Entente Powers, especially Britain, France, and to a smaller extent Russia. So neither side could call itself totally innocent, like usually it is the case in major wars. In addition to clear virologic differences between influenza and SARS-CoV-2, the virus that causes COVID-19, mean their courses are not perfectly matched. Today's citizens may consider the 2020 world to be dramatically more connected than in the past, because of, for example, the huge advances in mass transportation, airplanes, cars, helicopters, even ships are now much faster than a century ago, and of course the trains as well. And then the mass communications, mass media was still in its infancy a century ago, while today we have 24/7 live broadcasts, news broadcasts, both on the internet, on the television, and even on the radio. But World War I and soldier mobilization created a situation well suited to influenza dispersal because there were so many millions of soldiers still on the front and would remain for months even after the fighting stopped with the armistice of November the 11th, 1918. While the origin of the deadly strain of 1918 H1N1 remains obscure, evidence indicates that soldiers on the move drove circulation. Young American men left their homes, rural farms, small towns, crowded cities, and traveled around the world. They gathered by the thousands in military training camps and on troop ships, and then at the front in Europe, mostly in Western and Central Europe. Civilians globally continued to work in crucial areas of economic production that required movement through the same transit hubs that the soldiers used. The disease's first wave occurred in the spring and early summer of 1918 amid these movements, so roughly between March and June of that year. In the theaters of war in Europe, Africa, and Western Asia, soldiers mingled or mixed with their global compatriots. When they demobilized, they passed through major transit hubs back to their homes around the world, interacting with more people. The extraordinarily deadly second wave of influenza in autumn 1918 diffused linearly along rail and sea routes, then radiated outward to wreak havoc on previously unexposed populations globally. In some areas, this period was followed by a less deadly third winter wave of disease in early 1919. Medical historians conservatively estimate that influenza killed 50 million people globally, with 675,000 in the United States between 1918 and 1920. After that, this strain of flu receded, likely due to changes in the virus itself and the fact that most people had already been exposed and developed immunity or had died. This pandemic flu did recede. It's tempting to imagine today's pandemic following a similar trajectory. However, fundamental differences between the biology of SARS-CoV-2 and influenza viruses make it hard to chart the future of COVID-19 based on what happened in the early 20th century. The SARS-CoV-2 and the flu are biologically different. Uniquely, influenza's genetic material is organized in segmented chunks. This idiosyncrasy means the virus can trade entire segments of RNA with other influenza viruses, enabling rapid evolution. Influenza also has a distinct seasonality, circulating much more during the winter months. As virus strains circulate, oscillating seasonally between the northern and southern hemispheres' winter times, they mutate rapidly. This capacity for quick adaptation is why we need to get a new flu vaccination annually to protect against new strains that have emerged in our areas since last year. Coronaviruses actually do proofread their copied RNA to fix inadvertent errors during replication, which decreases their relative mutation rate. From the originally sequenced SARS-CoV-2 in Wuhan, China in December 2019, according to some satellite footage and photographs, there may have been an early outbreak already as early as in August 2019, in which case, if there has been a conspiracy at all, then the Chinese authorities involved have been guilty of that, because the communist Chinese government obviously usually does not want to quickly spread around the world, or allow to be spread around the world, news of such a major pandemic outbreak, because of course it means that the Chinese healthcare system and also the degree of sanitation in the fish and other seafoods markets will be severely criticized. To recently banked sequences from the US, there are fewer than 10 mutations in 30,000 potential locations in its genome. Despite the virus having traveled around the world and through multiple generations of human hosts. Influenza makes 6.5 times more errors per replication cycle, independent of entire genome segment swaps. The relative genetic stability of SARS-CoV-2 means that future peaks of disease are unlikely to be driven by natural changes in virulence due to mutation. It's also currently unknown if SARS-CoV-2 will be influenced by the seasons like influenza. All this means that oscillations in COVID-19 cases are unlikely to come with the predictability that discussions of influenza waves in 1918 to 19 might suggest. Rather, as SARS-CoV-2 continues to circulate in non-immune populations globally, physical distancing and mask wearing will keep its spread in check and ideally keep infection and death rates steady. As states loosen non-pharmaceutical interventions, the United States will likely experience a long plateau of continued new infections at a steady rate, punctuated by periodic local flares, and so will, lamentably, at least several, if not tens of other countries. This scenario will continue until the US population and that of several or many other countries gains herd immunity. In other words, that many people will become immune to the disease. But even if they have the disease in some form, they will not die of it. People seek answers from the experiences of influenza in 1918 to 19 for a fundamental reason: it ended. History shows the pandemic ebbed with a final third wave in spring 1919, so roughly from March to May 1919, without the benefit of an influenza vaccine, available only in the mid-1940s, so around the same time as the Second World War ended, so roughly a quarter century later. Or a molecular or serologic test, or effective antiviral therapy, or even the support of mechanical ventilation. Today, we're living through a novel pandemic. By and large, people are actively collaborating in unprecedented measures to disrupt transmissions of SARS-CoV-2. Scanning the historical record is one way to draw our own lives into focus and perspective. Unfortunately, the end of influenza in the summer of 1919, so roughly between June and August of that year, does not portend the end of COVID-19 in the summer of 2020, so between June and August of this year. The pandemic's scientific complexities are formidable challenges. They are playing out in a global economy that has ground to a halt, with resultant increasing pressures to reopen communities and a technologically advanced and interconnected society, all issues that our predecessors a century ago did not have to consider. This article was written by, for example, Jessica Pickett, who has a PhD degree, and she's a principal consultant with Tomorrow Global, LLC. So let's move on to Gavi, the Vaccine Alliance. So the question, how does COVID-19 compare to past pandemics? Most of the pandemics in the 20th and early 21st centuries have either been caused by an influenza virus or a coronavirus. The 2003 SARS coronavirus pandemic had a much smaller impact than this current coronavirus pandemic and killed under 1,000 people. And then several years later, the so-called swine flu around 2009 to 2010 also was relatively benign virus, although I think some tens of thousands of people did die worldwide, including something like 17,000 in the United States, if I remember correctly. But even its impact was relatively short-lived, and many people who never got the swine flu vaccine never developed its symptoms or caught it, for example, myself. Same with SARS. In terms of the number of deaths of COVID-19, it is actually more comparable with previous flu pandemics. The Asian flu in 1957 to 58 killed an estimated 1.1 million people, so roughly twice more than so far have died of the COVID-19, according to the statistics. The Hong Kong flu pandemic of 1968 to 70 killed 1 million people. The swine flu pandemic 2009 to 2010, according to the World Health Organization, reported only around 18,500 confirmed deaths, but probably considerably more people died of it. The US Centers for Disease Control and Prevention, CDC, estimated that it had probably killed between 151,700 and 575,400 people. Like COVID-19, the Asian flu killed mostly people older than 65. However, the Spanish flu killed mainly people between 20 and 40 years. Half of everyone who killed fell into that age category, and 99% were younger than 65 years. Apart from the devastating loss of life, the sheer disruption to normal life means that pandemics have long been predicted to damage the economy. Yet each successive pandemic seems to affect the economy more. Largely, responses to previous pandemics relied on hygiene and sanitation measures, such as hand washing, but not on lockdowns, physical distancing, or other measures that disrupt economies. In the 21st century, stricter control measures were starting to be implemented, which would greatly affect the economy. The 2002 SARS pandemic is thought to have cut the global GDP by 33 billion US dollars, despite under 1,000 people having died. A major reason for this was the blow to tourism to countries like Singapore and Canada. No pandemic is likely to have had such a brutal impact on the economy as COVID-19, which has triggered a near total shutdown of social and economic activity. The International Monetary Fund predicts that the global economy will shrink by 3% this year. A criticism of the lockdown approach: not too long ago, there were 2 or more really angry American women criticizing, for example, the requirement to wear masks, and one of them bizarrely even claimed that wearing masks can kill people. Well, perhaps certain people's chronic respiratory illnesses, such as asthma, can have more difficulty surviving. Is that it exacerbates privilege and wealth. People living on online and remotely suffer an immediate drop in their income, and the most vulnerable won't have savings to fall back on. In the low and middle income countries, so mostly located in Latin America, Africa, and Asia, but also in Oceania, the lockdown has shown clearly the number of people without securely housing, water, and sanitation, and reliable employment. Billions in Africa, Asia, and Latin America are without any possibility of locking out the coronavirus and are now facing devastating economic and health consequences. It is notable that a committee that advised the World Health Organization in 2019 on non-pharmaceutical approaches to tackle a pandemic did not suggest lockdown as a method of controlling the spread of disease. This is because of the enormous social and economic consequences that would hit the most vulnerable communities the hardest. About half of all jobs in Africa, and Africa has over 1 billion people, could be wiped out as a result of the current pandemic, and routine immunization disrupted, as well as access to treatment for malaria, HIV, and tuberculosis, and family planning. The number of people who are acutely hungry is set to double. Although it is far from certain how long we will live with COVID-19, it is possible that we will live with a seasonal version of the virus for many years to come. The current COVID-19 pandemic seems unlikely to be over anytime soon, with various scenarios for the future estimating either several overlapping outbreaks or another ferocious wave later in 2020. What should sound a note of caution for the world is that the second wave of H3N2 was also much more fierce than the first one, potentially because it mutated to become more deadly. And then to Smithsonian Magazine. Compare the flu pandemic of 1918 and COVID-19 with caution. The past is not prediction. I think this is, this is actually the original article that was copied largely to the Conversation website. Its original authors were Mary Webble and Megan Collar Freeman from the University of Pittsburgh in Pennsylvania, United States. This was published on June the 5th, 2020. Let's see if there's anything new to note here. Yeah, nothing new. So let's turn to Wikipedia. So according to Wikipedia, its English version, the Spanish flu, also known as the 1918 flu pandemic, lasted from February 1918 to April 1920. Infected 500 million people, about a third of the world's population at the time, or close to a third, in 4 successive waves. So there are various estimates of the death toll, either between 17 million and 50 million, according to Wikipedia, or even between 50 million and 100 million. Especially young adults, like soldiers who are still stationed on the front lines or returning from the front through especially passenger ships or even army ships and trains, they suffered high death rates. The 1918 Spanish flu was the first of 2 pandemics caused by H1N1 influenza A virus. The second was the 2009 swine flu pandemic. So the fourth wave was a very minor one, occurring in isolated areas including New York City, Britain, Austria, Scandinavia, and some South American islands. To this day, historians and epidemiologists argue why the 1918 influenza was called the Spanish flu. Several theories have been proposed about its geographic origin. The first confirmed cases originated in the United States. Historian Alfred W. Crosby stated in 2003 that the flu originated in Kansas, so the US Midwest, and popular author John M. Barry described that an outbreak in Haskell County, Kansas in January 1918 was the point of origin. A study made in 2018 of tissue slides and medical reports led by evolutionary biology professor Michael Worobi found evidence against the disease originating from Kansas, as those cases were milder and had fewer deaths compared to the infections in New York City. In the The study did find evidence through phylogenetic analyses that the virus likely had a North American origin, though it was not conclusive. However, it is also possible that the virus originated in Europe, because the major British troop staging a hospital camp in Etaples in France has been theorized by biologist John Oxford as being the center of the Spanish flu. His study found that in late 1916, so roughly 1.5 years before the virus really began, or over 1 year anyway, the Etaples camp was hit by the onset of a new disease with high mortality, causing symptoms similar to the flu. According to Oxford, a similar outbreak occurred in March 1917 at Army barracks in Aldershot in Britain, and military pathologists later recognized these early outbreaks as the same as the 1918 flu. And surprise, surprise, China. Because in 1993, Claude Anoun, the leading expert on the 1918 flu at the Pasteur Institute, asserted that the precursor virus was likely to have come from China and then to have mutated in the United States near Boston, Massachusetts, and from there spread to Brest in northwestern France. Europe's battlefields, the rest of Europe and the rest of the world, with Allied soldiers or Entente soldiers and sailors as the main disseminators. Anoun considered several alternative hypotheses of origin, such as Spain, Kansas, and Brest, as being possible but not likely. In 2014, historian Mark Humphreys argued that the mobilization of 96,000 Chinese laborers to work behind the British and French lines might have been the core source of the pandemic. Humphreys of the Memorial University in Newfoundland, Eastern Canada, based his conclusions on newly unearthed records. He found archival evidence that a respiratory illness that struck northern China, where the laborers were originally from, in November 1917 was identified a year later by Chinese health officials as being identical to the Spanish flu. However, no tissue samples have survived for modern comparison. And then the coronavirus disease. Common symptoms include fever, cough, fatigue, shortness of breath, and loss of smell and taste. While most cases result in mild symptoms, some progress to acute respiratory distress syndrome, or ARDS, possibly precipitated by cytokine storm, multi-organ failure, septic shock, and blood clots. The time from exposure to onset of symptoms is typically around 5 days, but may range from 2 to 14 days. The virus is primarily spread between people during close contact, most often via small droplets produced by coughing, sneezing, and talking. The droplets usually fall to the ground or onto surfaces rather than traveling through air over long distances. However, research as of June 2020 has shown that speech-generated droplets may remain airborne for tens of minutes. Less commonly, people may become infected by touching a contaminated surface and then touching their face. It is most contagious during the first 3 days after the onset of symptoms, although spread is possible before symptoms appear and from people who do not show symptoms. The standard method of diagnosis is capital RT-PCR from a nasopharyngeal swab. Chest CT imaging may also be helpful for diagnosis in individuals where there is a high suspicion of infection based on symptoms and risk factors. However, guidelines do not recommend using CT imaging for routine screening. As of now, early July 2020, there are no vaccines nor specific antiviral treatments for COVID-19. Management involves the treatment of symptoms, supportive care, isolation, and experimental measures. The World Health Organization declared the COVID-19 outbreak a public health emergency of international concern, PHEIC, on January the 30th, 2020, and a pandemic on March the 11th, 2020. Local transmission of the disease has occurred in most countries across all 6 World Health Organization regions. We'll keep monitoring the situation. Thank you so much for watching this video lesson and stay safe.